Professor Park, thank you very much. And if you have any question to Dr. Ogura, please join to the next session. Okay, so session 2, Professor John, could you please chair?
Let's get started. Second session. This session seems a kind of special. The speakers will present lectures based on evidence and experiences on frequently asked questions about biliary stent, which were surveyed by pancreas and biliary clinicians in most countries. First lecture title is Answer to Pre-Questionnaire from Korea. What characteristics should an ideal SEMS or a plastic stent used for EUS HGS PEP? And Dr. Takeshi Ogura will give a presentation. He is currently working as a professor at Osaka Medical College. Dr. Ogura, please.
Okay. I will share video. You can see here. Okay. Thank you for your good introduction. So it is my great honor to present my lecture in this meeting. So I'd like to talk about what characteristics should an ideal SEMS or plastic stent used for EUS HGS have. First, I'd like to show the video. The intrahepatic bile duct is punctured using 22 gauge needle. You can see the bile duct stone. So this patient underwent pancreatoduodenostomy. So hepaticogastrostomy structure is complicated. So we tried to use HGS. So after the guide wire insertion, we insert the dilator catheters. And then contrast medium injection again. Multiple intrahepatic bile duct stone can be observed here. So after guide wire inserted, we try to insert the central system into the intrahepatic bile duct. So we try, so this was carefully performed from the intrahepatic bile duct to the stomach. We successfully performed EUS HGS. We can select various stents, including self-expanded metal stent or dedicated plastic stent during EUS HGS. Today, I'd like to talk about following subjects regarding basic strategy of EUS HGS stent selection. First, which should we choose, plastic or metal stents? Generally, plastic stent is mainly indicated for benign biliary strictures, and a metal stent is also used for malignant biliary obstruction. But my recommendation is to use metal stents. Following subjects benefits of metal stent during EUS HGS. Metal stent deployment can prevent bile leakage, make certain fistula, and obtain effective drainage because of its large diameter compared with plastic stent. In addition, biliary access is easy through EUS HGS route. Recently, expanding indication of EUS HGS, such as antiquated stone removal or stricture management through EUS HGS route, has been reported. So we also previously reported peroral transluminal cholangioscopy. If metal stent was deployed, various devices, including SPY-DS, can be easily inserted. I'd like to show the video. This patient underwent total gastrectomy, and common bile duct stone was complicated. So we tried to EUS HGS. And then after 1 week, we tried to stone removal through the fistula. First, ERCP catheter is inserted and the contrast medium injected. You can see here a relatively huge bile duct stone. So we remove the metal stents, and then SPY-DS was inserted antegrade. So we try to EHR like this. So stone fragmentation can be obtained. So next we insert the basket catheters. So we usually remove these stones transluminally. Compared with antegrade stone removal, This procedure has no risk of acute pancreatitis, so we try to usually this technique. However, as shown in this video, tract dilation is needed if EUS HGS is performed using a plastic stent. In this situation, fistula may be broken during tract dilation, like this. Therefore, if various treatment will be applied, metal stent has clinical benefit compared with plastic stent. However, when EUS-guided antegrade stent deployment with EUS HGS is applied, plastic stent may be suitable in viewpoint of cost effectiveness. So we usually, after antegrade stent deployment, to keep the fistula, we place a plastic stent. In short summary, to prevent various adverse events, metal stent may be suitable compared with plastic stent. To perform various antegrade treatment, metal stent may be safe because tract dilation is not needed. Plastic stent deployment may be favorable when EUS-guided hepaticogastrostomy combined with antegrade stenting is applied. Next, I'd like to talk about following subjects. Which diameter of metal stent should be selected? I think larger force is needed to prevent dislocation into the stomach. In this study from Japan, 6 mm diameter was mainly used. Compared with 10 mm diameter, larger force is small. Therefore, to prevent dislocation, I like to recommend 10 mm diameter. As I mentioned previous slide, 10 mm diameter may be ideal, but if stent deployment is performed the periphery of the bile duct like this, hyperplasia will be easily occur. Therefore, we should pay attention to site of distal end of EUS HGS stent. Next, I'd like to talk about partially or fully covered metal stents. As you know, if fully covered metal stent is deployed, focal cholangitis can be sometimes complicated due to side branch bile duct obstruction. On the other hand, hyperplasia is one of the disadvantages of partially covered self-expand metal stent, as Dr. Park mentioned. Therefore, hepatic bile duct, which is usually dilated bile duct site, is ideal at the distal end of EUS HGS site. Next, I'd like to talk about braided type or laser cut type. Recent dedicated self-expand metal stent for EUS HGS is braided type. These characteristics aim to prevent stent migration, but also dedicated self-expand metal stent is used. Stent migration can be complicated. To prevent stent migration, intra-scope channel release technique very useful. So after the stent delivery system is inserted, you should pull the stent delivery system to obtain adhesion between hepatic parenchyma and stomach wall. Pull the stent delivery system. Then stent release is carefully performed from the intrahepatic bile duct to the echo endoscope up to 2 or 4 cm, like this. By doing so, stent release was certainly performed across the stomach wall, so we will prevent stent migration. Stent release was finally performed under endoscopic visualization, like this. Indeed, adhesion between hepatic parenchyma and the stomach wall can be obtained. However, this technique may not be easy for non-expert hand. So recently, novel laser cut type metal stent has been available in Japan. This stent has 2 cm long anchor side, and stent delivery system is only 7 French. Larger force of laser cut type self-expand metal stent is smaller than braided type. Therefore, deeper notch, as shown in this figure, is formed after stent deployment. So I'd like to show the video. This patient underwent duodenal stenting, but pancreatic and bile duct obstruction complicated. So First, we performed EUS-PD using plastic stent like this. So next, following EUS-PD, we performed EUS HGS. The intrahepatic bile duct is punctured using 90-gauge needle, and the guide wire is inserted. Because this stent delivery system is 7-flat, we can insert this stent without tractoration. And the stent release was carefully performed from the intrahepatic bile to the stomach using intra-scope channel release technique. So we successfully performed EUS HGS and EUS-PD. These pictures show the benefits of laser cut type self-expander metal stent. Due to deeper notch, stent migration difficulty occurs. Therefore, especially for non-expert hand, laser cut type may be suitable as EUS HGS stents. Summarize to prevent dislocation, 10 mm diameter and 10 cm or 12 cm length and partially covered self-expander metal stent may be ideal. Especially for non-expert hand, laser cut type self-expander metal stent may be suitable. Also, this type is only available in Japan, maybe. However, we cannot remove laser cut type self-expander metal stent. This is a disadvantage of laser cut type. Finally, I'd like to talk about HANARO one-step stent deployment technique. As we all know, HANARO benefit has been available in Japan. This stent is only 5.9 French. Therefore, we can insert this stent delivery system without dilation. I'd like to show the video. The intrahepatic bile duct is pumped using 90-gauge needle, and the contrast medium is injected. Then we insert the 2.5-inch guide wire is inserted into the like this. And then we insert the stent delivery system. We smoothly can be inserted. And then carefully stent release was performed from the intrahepatic bile duct to the stomach. This procedure is only 7 minutes. We successfully performed EUS HGS. This is final slide. To date, we performed this procedure in 14 patients, and their favorable outcome were obtained. However, we experienced 2 focal cholangitis patients. Therefore, partially covered is strongly needed. So to please make this partially covered metal stent. Thank you for my Korean friends. Thank you.
Thank you for very nice presentation and beautiful last photos. The floor is now open for discussion. Is there any question or comment? Dr. Park?
Yeah. Dr. Ogura is a very excellent presentation and talk. It's very impressive. I have one question or comment because you have already may have a Korean stent, but Okuno Edo is maybe a Hara group has published in a 6 mm diameter stent before is focal cholangitis, but this almost maybe have a 10 mm stent, and there's a little bit some HANARO stents is inside. So I mean the Korean stent has a different open design or membrane. So even though there's the same diameter, the radial post is so different. I think maybe this reason why you are recommend is 10 mm because some stent is a 6 mm is not so good for radial force in some Korean stent, but some Korean stents is better in the 6 mm diameter even though. So, and I think yours impressive is a self-French of the free curvature matter is M.I.Tech stent is good for, I think it's a good option. But is my concern is sometimes is there is a distal, some anchoring point is maybe important because for beginner sometimes it's even though wrong stent, but sometimes maybe there's accident inside of the or peritoneal distal or stent migration may be possible, I think so. But I think it's very impressive and very good for option with this it's a self-French with a dilation of the very thin stent is a very good option, I think. Yeah.
Okay, thank you for your comments. You mentioned compared with another stent, HANARO stents have good radial force, or
Yeah.
even though 6 mm diameter.
Yeah, I think.
Okay, okay, I agree with your opinion. Thank you for your comments.
Okay. Next question is Dr. Matsumoto, please.
Okay, thank you for your nice presentation. So I have two questions. So first, how to manage stent obstruction with hyperplasia? So, insert plastic stents or metallic stents. So second question is, so you mentioned the one-step technique stent deployment. So how size, how range can you insert one-step EUS HGS?
Okay, thank you for questions. First question is the intervention. So we, depending on patient survival, if patient survival over 6 months, we usually place uncovered metal stents or fully covered metal stents. And if patient survival will not be so long, we deploy the plastic stent. Second question is once deployment. As you mentioned, fine gauge stent delivery system is very important, but as Duyan Park mentioned, pushability is also needed. So it is a very difficult question. Duyan Park, how do you think?
Basically, so I agree with you because fine gauge is sometimes very easy for the B2, but sometimes B3 position, there's angulation, there's a slipper over the some metal stent, even though there's a fine gauge. So this reason why I used some good pushability for one-step device, as it's very similar one the Sohendra stent retriever, I think.
Okay. Next question is Dr. Kwon, please.
Thank you. Thank you so much for your excellent presentation.
Hi.
I have a short question. Do you think what's new benign indication of HGS, especially operation-related strictures? What do you think about new indication of benign disease?
Please wait. Please, your voice is not clear, so please.
Yeah. Do you think what's new indications, especially benign disease?
Okay. So my good indication for benign barrier stricture, we can hepaticogastrostomy stricture is very good indication for EUS HGS. So we previously reported antibiotic stent deployment through the EUS HGS route. So the intervention is very easy, short procedure time compared with intra-scope. So hepaticogastrostomy stricture treatment may be a good indication and a novel treatment option, maybe.
Dr. Ogura, thank you again for a nice talk and comments.
Thank you for your